Okay. All right. Well, it's 1:15 and I'm going to go ahead and get started. I would like to welcome you all to this invited symposium on social work and public health. Today we have two panelists. We may have a third joining us. In the Zoom world and all things, people come in, they can't connect. But we have with us today Professors Gino Aisenberg from the University of Washington and Professor Tina Sachs from the University of California, Berkeley. I'm going to let them introduce themselves to you, and then we're going to start it off with a question for them to begin this dialogue. There are not going to be any PowerPoints, so we'll just have a great discussion with these scholars and researchers on the topic of social work and public health. If you have any questions, please put them in the chat. I'm going to monitor that, or raise your hand, and I'll try to get to those questions as soon as I possibly can. So thank you for joining us today. I ask that you do place your mics on mute so that any background noise won't be picked up. And without further ado, let's begin the introductions. Dr. Sachs.
Thank you so much, Dr. Miller, for that setup of our conversation today. I'm really excited to be here with you all. I'm so happy to have a conversation with Professor Aisenberg. So my work is essentially around discrimination, how structural discrimination affects women, particularly women of color, in the healthcare setting. So at the point of service of receiving healthcare. My book is called Invisible Visits: Black middle-class women in the healthcare in the American healthcare system. And I essentially was interested there in the intersection of race, class, and gender, and how women who are not additionally burdened by poverty are affected by discrimination, intersectional discrimination, forms of discrimination in healthcare settings. And before I came to Berkeley, I spent a long time working in public health. I worked at the Centers for Disease Control and Prevention for about almost 10 years, where I did various kinds of public health policy work. I worked at the National Center for Environmental Health, the National Breast Cancer Early Detection Program, and many other public health programs, as well as worked at the City Baltimore Health Department. So I have sort of my work has always been at the intersection of public health and social work. So I'm really excited to be here. Thank you.
Well, for me, it's good morning to everyone, but good afternoon to you. I'm Gino Aisenberg. I'm an associate professor at the University of Washington School of Social Work, and I am the founder and co-director of the Latino Center for Health, an interdisciplinary research center that's really shifted the paradigm to engage with community partners to actually identify what are the strengths and needs, and the responsibility of the center is then to bring resources to bear on their issues and concerns, and to inform policy and practice. So that's very intentful purpose. I'm not trained in public health, but my early career in research in terms of community violence, I certainly am a beneficiary of some of the methodology of public health in trying to address violence in the community. I've just stepped out of my role previously in the graduate school, where I served as associate dean for equity, diversity and inclusion, and student affairs, and have returned full time to my faculty position. I think one thing that is another area for my research is in terms of partnering with the community, especially with regards to mental health and depression care in Central and Eastern Washington, more rural parts of our state, with the Latinx communities, to provide evidence-based telephone delivered cognitive behavioral intervention. And what's been exciting is to develop a training and curriculum program to train bachelor students at one of the local universities in the region to train seniors to deliver this intervention to patients of a large network of clinic sites called the Yakima Valley Farm Workers Clinic. So look forward to engaging with you, and hopefully it's growthful and beneficial for all. So thank you.
Thank you thank you very much for those introductions. I hadn't heard Yakima in quite some time. I spent a lot of time there when I was in the service. So to kind of get started here, we all know, as you said earlier, Tina and Gino, COVID-19 has been with us now almost a year. And we understand and we hear and we read about the impact that it's had on communities of color, marginalized populations. From your vantage point, could you talk about how COVID-19 has really affected marginalized communities, vulnerable populations, particularly women, particularly the Latino, Latinx communities? And what can we do, or what should social work and public health be doing to address those issues? Who wants to go first?
It doesn't matter, Tina.
Okay, I can go first.
Okay.
So, so I think it's really, what we've seen here is really an unearthing of what we have all known to be the case, right? We know that these structural inequities exist. We knew from the very beginning, I think, that they were more likely that they would disproportionately affect people who were vulnerable based on all kinds of different social vulnerabilities, immigration status, people. I think one thing we haven't talked about too much either is disabled people, people who are incarcerated are incredibly vulnerable here, both in immigration detention facilities as well as in the rest of the kind of carceral apparatus that we have built up here in the United States. And so we just have so many people who are vulnerable across race and socioeconomic status, gender, ability, everything, right? And so what we have seen here is really, I think, a reckoning, very much in the spirit of the reckoning that we have seen last year in terms of the racial justice reckoning that we've experienced. And I think I really have liked the writer Arundhati Roy, who has said that the pandemic is a portal. It is an opportunity to think about a different world, so that the structural inequalities that we see here, that we may be able to do something about them. And so what I see is the structural inequities that are built in here are things that we typically would think about in social work, right? Are the social determinants of health, are housing, access to care, environmental justice, not living in neighborhoods like we know that many Black, Indigenous people of color do, that have high particulate matter. So you have people who are more likely to have asthma and underlying conditions that put them at greatest risk for mortality from COVID. So these are things that we already that we could have expected as social work and public health scholars and people who are interested in these kinds of problems. But I hope that now maybe that we have an opportunity to do something about the things that we know would help people in terms of COVID, but also the social determinants of health more broadly.
Thank you, Tina. I think, within the Latinx and Black communities and other marginalized communities, the pandemic has certainly illuminated the longstanding legacies of unequal treatment, unequal access to quality healthcare, including mental health services. Mm-hmm. The elevated risk that members of these communities experience due to the shortage of Latinx and Black physicians. What you shared, Tina, in terms of the social determinants of health, we know about that and how it has negatively impacted for generations communities of color. It also is reflected in the lack of systemic use of translation, so that a big issue has been the lack of trust of information that's being communicated, and not even having consistent access to trustworthy information, which influences decisions. Communication not being understood, the lack of linguistically appropriate communication. The detriment, especially within the Latinx community, being essential workers, and then not being, often living in intergenerational or multi-generational households. So the space is not even conducive to maintaining the proper distancing that is recommended. All of those are contributing factors, and they don't resolve themselves by single focus approaches. It requires comprehensive and sustained commitments to address the structural issues and factors that contribute to these inequalities and inequities. One thing that the Latino Center for Health has done, we were commissioned by the state legislature to examine the shortage of Latinx physicians in the state, because in our state, Latinx communities were disproportionately impacted, not only at the beginning, but even currently. At the onset, 44% of cases, COVID-19 cases, were comprised of Latinx individuals, even though only 13% of the state population is Latinx. In terms of deaths, Latinx individuals are 4.2 times more likely to die from COVID-19 than whites, and that's age adjusted. In terms of physicians, we found only 3.1% of physicians in Washington state identify as Latinx. There's not enough students enrolling in medical schools or in residency programs. And so when you don't have a trusted health provider who can communicate in your preferred language, there's going to be challenges in terms of the care. And now, from that report that was issued in October, we're working with state legislatures and to have new legislation enacted. We know this legislative session is a little bit different, not only because of doing it online, virtually, but because of the economic considerations. So we put forth two of the key recommendations of the report were to establish population parity across the public schools of medicine in the state, so that newly enrolled medical students would reflect the population of the state. So currently for the Latinx population, there's only 7.1% of medical students are Latinx, compared to, as mentioned, nearly 14% of the state population, and it continues to increase. Similarly, we have asked for population parity by 2025 in the residency programs, and we're working with international medical graduate advocates to create a pathway in terms of medical schools that they can be accelerated, because they've already been licensed as physicians in their home countries, but they can't practice medicine as physicians here. So that's just a few of the recommendations from the report, but we're concretely engaging with community organizations and elected officials to create policy changes that can begin to address this one aspect that has certainly intensified our understanding about the critical shortage of Latinx physicians in the state.
Thank you very much for those responses and information. And there's a lot to unpack in that information. We know that's out there, systemic issues that have been around for generations. It's as if COVID has pulled back the veneer. But a question I want to ask you both. COVID has exposed the issue of the digital divide. You both mentioned information or lack thereof. How has the digital divide or digital silos affected health delivery, access to services? Something simple as telehealth or telemedicine. I know in Yakima, it's out there in the Yakima Valley. So how has something that we all say, oh, we just go on Zoom or we meet, we do this, but how has that affected disparities, and how can social work and public health address that?
Mhm.
Yeah, I think that's an important question. It's rooted, I think, in our assumptions. Everyone has a laptop. That's not true. That everyone understands the technology. You know, I know I'm still learning this technology in terms of trying to engage my students and its capacities. But the lack of high quality access to consistent internet access and computers limits the access to crucial information that is needed to make informed decisions and choices. Access to physicians and healthcare providers. We're beneficiaries of education, and you know, I'm a parent of Rebecca, 21-year-old daughter who has Down syndrome, and it would take more than a year just to tell you the advocacy efforts that we've had to engage with the school district to provide meaningful quality education experiences for her and others. My wife is now a retired educator. We're articulate. We can advocate. We're not intimidated by the system. But when you're talking about others who may be coming from backgrounds where or countries where access to education may be limited to elementary school level, to expect them to confront systems that are not well equipped to be responsive, to listen to, and then address their needs, the power differential is too acute.
Mhm.
And it isn't just in health. I mean, we know as in terms of education, it's like, what do you do? And parents not understanding how to be primary teachers of their children in terms of subject matters that, you know, are they going to be teaching algebra? Not necessarily. So one clear result is also the fact that many low-income, marginalized communities and individuals in those communities don't have a identified primary care physician. And so what happens is that they're going to be accessing the ER or urgent care facilities as their go-to place for care. And there's going to be gaps in the communication and service delivery as a result. You know, so the digital divide in terms of accessing information, as well as the ability to advocate within those systems and get responsive action contributes to a further distancing, a further lack of access to critical information in terms of making informed decisions as well as accessing appropriate services.
Thank you. Dr. Sachs.
Thank you for that. I think, Gino, you really encapsulated so many of the challenges that we face here, again, going into this kind of brave new world in which who knows if we will go back to, we all are thinking kind of about going back to normal. And at one point, and it sort of in one way too, I think we need to certainly problematize what normal really was before, because it really wasn't so great for a lot of us. But also to think about, are we always going to do telehealth? Are we going to go back to providing most of our services via this platform or some other kind of virtual platform? And one of the questions here in the chat about whether this is an issue for advocacy in terms of social workers to think about. I think the way I see this is really that certainly the telehealth and using these virtual platforms has sort of liberalized access to care for some people. And has made it so that people might be able to access, for example, mental health services in their own home, perhaps with less stigma. I'm not sure about that, but I could imagine that people might feel like, okay, well, I can do it in my home. There's no stigma, so I will do this now that I can access this through kind of an online platform. But we know that for other people that this is not the right platform, that they don't have access to it, they don't understand it. And there is also certainly this kind of impersonal virtual nature that just doesn't work for some people. And so I think in terms of social work advocacy is really, again, it goes back to some of the very simple principles or tenets of social work of starting where the person is and really trying to understand what they need in terms of advocacy, trying to perhaps get them access to, being able to use their phone to access a provider or something like that. I think this is really going to be particularly important and actually critical for the nation going forward, is how we're going to try to get access to the vaccine for populations that don't typically have access to a regular source of care. And this includes people who are both uninsured, people who are undocumented, people who are living in rural areas. And so trying to think about coordinating, through using some app to coordinate your first dose of vaccine and then come back 3 weeks later for a second dose. And this is just not something I think that's going to be accessible for a very, potentially large segment of the American population. And I think this is something that we really need to try to put our heads together around, is like, how are we going to try to use technology for the people for whom it works, and how are we going to use just regular old boots on the ground, shoot regular old knocking on doors, home visiting approaches to try to get people access to the vaccine who really, for whom using technology is not going to work as effectively.
Thank you. Thank you for that. Thank you for those responses. There's a question that's in the similar vein around the digital divide. And Dr. Sachs, I'd like you to begin with that. Is how can social work and public health really advocate for this new approach in the current environment in which we live regarding telehealth access? Because a lot of folks don't have data plans or smartphones to access this new wave, but they still need the healthcare. And you both touched upon it. So could you expand on that for a bit, please?
Sure. I mean, I do feel a little bit out of my depth in terms of technology, even though I'm at Cal Berkeley, where technology and in the Bay Area is a really, really big part of our lives. But I think it really does. It sort of goes back to kind of what I was saying earlier, that I think there must be some ways of getting the technology to people who need it the most, in terms of perhaps providing data plans to people, providing phones. I know that all over, or I have heard that in much of the developing world, people really use their phones to great effect. They don't have laptops. And so people use their phones as a way of of connecting with the rest of the world and with people in their communities and getting information and so forth. And so certainly, I think also that in the United States, in which we often say we're the richest country in the world and so forth, I think that we need to really put our money where our mouths are in terms of infrastructure, and technological infrastructure is a part of the kind of built environment infrastructure that we typically talk about. And so why can't we then provide healthcare or provide phones and data plans to people who really need them to be able to access care? And perhaps that's a sense of, a site of advocacy that social workers could engage in. I think also simultaneously not losing sight of the other kinds of infrastructure in the US, like community health centers that really do, and federally qualified health centers that really do a lot of the work of engaging community partners and people who are more vulnerable in the community to get access to care that way. So I think this really has to be a both and approach. And we tend to think about, we don't have money for this or whatever, but the reality is, we do have money in this country for what we think of as a priority. And I think some of what we continue to have to do as social workers and scholars of the social world is to keep fighting the good fight and to keep saying that that our lives matter, that people of color matter, that Black lives matter, that all of the people that we tend to lump into sort of minoritized, marginalized groups matter. And if we matter, we should get funding for the things that keep us safe and healthy. And so anyway, I could go on a lot more about the things that don't necessarily keep us safe and healthy that we fund, but I think we know what we need to do here. And perhaps we have an opportunity with a new administration to push on them and to say, the kind of, Black, Indigenous, persons of color, this kind of, multiracial coalition that delivered the Senate in Georgia and that potentially delivered the presidency to the new administration, has a responsibility to also address some of the underlying structural problems that those communities face.
Thank you. Dr. Gino, you want to add something?
Sure. I think it's critical in thinking through this that we not simply rely on what practices we've implemented in the past, because they weren't necessarily working. And in terms of engaging with communities, especially communities of color, we are less likely to listen well to them. And I'll give a lived example that was many, many years ago. White Center is a area south of Seattle that is a hub for recent immigrants, whether Vietnamese, Cambodian, Latinx communities to land, okay? Starbucks wanted to build a park for the residents. It would be the first big park in the locale, in the neighborhood. It had one community meeting and it had a flyer, one page in English. The backside had maybe 5 sentences for the other language populations. That was the only input that Starbucks sought. They built the park, and then they were upset when the community residents weren't using the park as fully as they had anticipated. Why? Because they chose to use bark as the landing spot by the swings that the residents did not want. They thought it was an unsafe area for their children, so they didn't utilize it. The fact that we create policies and programs where we fail to listen to the wisdom of the community, what are their aspirations and what are they actually needing? We must move away from that paradigm, that practice. Partnering with community organizations is critical. In terms of areas of mistrust, one example that I can share is the Pacific Northwest Agricultural Safety and Health Center at the University of Washington School of Public Health. I collaborated with them in the Yakima Valley region with the onset of the pandemic. People were not wearing masks. It was like 5% of the population in June were wearing masks at that time. they engaged local resources, the local radio station in Spanish, doing flyers, meeting with individuals at community events and whatnot. They were trusted communicators of accurate information. And by August, the usage of mask went from 5% to 95%. So change can happen when people are properly informed through trusted sources of communication. And that isn't necessarily that we know. As researchers, we're not always the trusted partner because we've practiced legacies that have been harmful and oppressive, where we pop in and pop out, get the data, but not necessarily provide meaningful change to the organizations or to the community. So there's things that we can do also, even at, highlighting the need. I mean, in Washington State, this report that I mentioned on the physician shortage of Latinx physicians, when media was highlighting COVID cases through the summer, despite the disproportionate representation of Latinx individuals, the focus was on the white population. So we went on a media campaign to spotlight the need. And why are you avoiding recognizing in your articles about this disproportionate representation? Even now, some organizations don't even collect racial ethnic data because they don't want to look bad. Well, we have to shift that. We really have to shift that and challenge those practices. We can host webinars to provide information that is more trustworthy, that is accurate, and engaging the community. So there's clear need to engage communities in authentic partnerships so that we can bring about effective change. I chuckled in speaking about the use of cell phones because being now a little bit more senior faculty, when I did the original study that was funded by NIMH in the Walla Walla region of the state, the telephone depression work, I was using it was in 2010 and I was using a flip phone, okay? I mean, that was the technology. We didn't even have FaceTime at that point, but it worked really well. And it wasn't, even for the migrant workers, there wasn't a limitation. Most had cell phones at that point in time. And to my surprise, many people, especially including men, really appreciated the use of the telephone. Why? It was less stigmatizing. They didn't have to go in their rural, smaller communities to the clinic for mental health and be seen by neighbors and friends and then be questioned, what were you doing going over there? And so it provided a level of anonymity that was welcomed by them. I thought originally that we would send the manual to the participants, that they would hide the manual. That was not the case. They were empowered by having language that spoke to experiences of like, why do they feel so low energy? Why is it difficult to get out of bed? They didn't understand. And now to have language that helped them to understand their experiences, they were freely sharing with partners, with spouses, with their children and relatives and neighbors. They weren't ashamed of having depression. And it was so liberating for them through that experience. And so providing resources, including making the treatment services available at their preferred time. So if it was Wednesday night at 9 p.m. after soccer or 7 o'clock on a Saturday morning, they would receive their session. So they trusted the process, and they're trusting the process now with the bachelor students, and are grateful for the services. We're providing services that aren't available. I mean, when we did the original study, there was no psychosocial services available in Spanish in the entire region, except at the VA hospital, which was serving a limited portion of the community. So
With this, because I want to jump in because there's a couple other questions I wanted to get to, and I definitely want to get the audience involved. Social work, public health, they've had this marriage for 100 years or so. We see that there are these significant issues. From your vantage point, and briefly, what has worked regarding social work and public health and addressing the needs that you both clearly highlighted? And in what areas, based on Dr. Lindsay's talk yesterday, being unfaithful angels, that we as a profession need to look at ourselves and address? And so I want to volley back to Dr. Tina on that. What have we done in terms of social work and health, that this marriage that we have, this lasted 400 years? What's been successful, and what do we need to do to increase the communication? As Dr. Gino mentioned, there's some distrust, and let's be 100, as the kids say. We need to look at our own house as social work professionals and as social work researchers. We parachute in, get the information, and then leave and don't go back. So how can we address that going forward?
I think, certainly these, as you just frame the question, this has been an ongoing issue. It probably, it certainly predates us, and it will probably go on past us, right? Because it's sort of it unearths a tension that is, in some respects, hard to address for some people. And I'm also just sort of responding here to one of the questions I see in the chat, which also relates to this, about how do we, work in community without perpetuating power imbalances, right? And so I think some of the things that have worked in the relationship between social work and public health have been very simple things about going into communities, doing contact tracing, getting people to, developing relationships with people so that we can understand what people's primary concerns are, as well as trying to understand how we might address them. And we know that for both, these sort of complementary professions, that there are just enormous, that really all of this is predicated on trust. And trust is something that is really hard to earn, and you can lose it quickly, I think. And I know when I used to work in Baltimore, I was a social worker working in the public health department in Baltimore. And this was really at the height of our, in Baltimore at the time, it was really, when The Wire was the popular show, and we were really battling an opioid epidemic, in which the people who were unfortunately affected by this epidemic were not what we see in the news today, but these were all very vulnerable people. Certainly people who are affected by the opioid epidemic are vulnerable people today, but all I'm trying to get at is that these were Black people at the time that were affected by the opioid epidemic. And I was going into communities and trying to tell people, we need to open a new treatment center, to a substance abuse treatment center, and we want to do it in this particular neighborhood. And they were kind of like, you're here from the government and you're not here to help, and we don't want you here, right? And so these are the kind of perennial challenges that we face. And I don't think there's an easy answer to it, because certainly social workers have been really implicated in a lot of very, very troubling things, certainly acting as arms of the state, and going, taking people's children away, all kinds of things. And so I think what we really must do as individuals is to understand that history is there. And it's not always just a history. It happens in the contemporary moment as well. But we need to understand the context in which we are working as social workers, to understand and really check ourselves and check our own sense of why we are coming to this field. Why are we doing this work? Are we doing this because we have a savior complex? Do we have our sort of own ego tied up in this? And certainly we all do. We all want to, want to do well, and we all have a sense, I think, a unifying sense of fighting the good fight. But we have to continuously check ourselves and try to reflect on what we are doing there, and what some of the unintended consequences of our actions might be. The unintended consequences for vulnerable communities, much as Dr. Gino was referencing with that park, right? Like they intended for it to be a great park, but they didn't really understand that some people wouldn't like the kind of material they used, and it turned them away. So these are things that I think it's just a constant process of checking in with the community, really listening, and really trying to understand what is it that you need, as well as we know for both public health and social work, we know what facilitates well-being. We know some of these things, right? We know that people need housing. We know that people need health insurance and access to care. We know that people need to be able to have a living wage. And so these are really issues, social policy issues, that are at the intersection of social work and public health. And that to my mind, I think that we could be perhaps really organizing around to say, if we did something about the social determinants of health, and particularly how those social determinants intersect with race and racial inequalities, I think then we might be able to make a dent in the kinds of disparities that we continue to see.
Thank you, Tina. Would you like me to respond, David? Okay.
Yes, please. And then I'm going to open it up for the audience.
So I'll try to be a little bit brief. I think what struck me, Tina, was about listening, but listening with respect. Okay, listening with respect, valuing what communities are contributing, and having them invest in the process as well is critical. But one level of I relish the intersection and the commonality of commitment to social justice between public health and social work. But I'm also aware that within our academic institutions, there's not always a lot of collaboration of faculty, okay, across what would be natural fits. And we need to look at that. We need to address that. If we're going to be providing leadership, it can't be in this compartmentalized, fragmented way, not with these deep-rooted issues that require, sustained investments and effort to address the social determinants of health, and have the ganas, have the commitment to actually do it. We can't continue to pretend they don't exist. We're knowledgeable enough about them, but they still persist because of other factors. But it's also concerning to me that in many of our programs of study in public health and social work, there's still a tremendous need to increase the number of faculty of color who can serve as role models and mentors. The curriculum often, at least, can be focusing on evidence-based practices, on practices that were normed on dominant culture populations that are oftentimes not taking into account different communities, American Indian, Black, Latinx, Southeast Asian communities and their experiences and practices. So we have an opportunity and a responsibility within our programs of study across the country to also make the necessary changes so that students can see them, students, especially from underrepresented communities, can see themselves in faculty, but also see themselves in the curriculum and don't have to advocate for an additional course because of the glaring need and gaps within their program of study. that's one area that we can make progress in. Partnering with community takes investment. And I just will close with, oftentimes our academy doesn't support junior faculty on the tenure track, partnering with communities, because it takes time to invest, and it's not producing quick results. And so you have conflicts at a structural level that we have to address and work through to provide the necessary leadership.
Well, thank you both for that very, very insightful responses to the questions. What I want to do now is open it up to the audience. You have questions for Dr. Tina or Dr. Gino, you can put them in the chat, or you can just jump in, unmute yourself. Also, I just want to remind you, there's a poll, I think. Please, before you leave and rush off to the next session, please complete that for SSWR so we can have that information and really make this going forward a very, very useful opportunity for us to continue to learn and dialogue. And also, please tweet out to your network that SSWR is rocking right here on the virtual network. Okay, so have a question. Let's see. There are two questions. I wonder the role of adopting a multidisciplinary framework and understanding the nature and extent of health and mental health disparities, promoting interprofessional practice. Do you to address the issues we discussed today? How can we do this better interprofessionally? Who wants to take that first one? Then I'll get to Ms. Smith's question.
I'll defer to Tina, but I mean, one idea is, yeah, that framework is awesome. I also would include, and it is an investment of resources, that you have co-instructors delivering that. So there's multiple perspectives, and finding ways to include the perspective and voice of community, whether as guest presenters or whatnot. But yeah, multidisciplinary is a strong, it is a strength if we can practice that.
Dr. Tina?
No, I just would echo that. I think, trying to think about like sort of interprofessional training as this, as the respondent has suggested here, is a great idea. And I think to hopefully be thinking about structural competency and how we can train both, nurses, public health practitioners, social work practitioners to think about the structure of society and how we might intervene there, as well as on the individual and sort of, meso level, is something that's important to consider as we go forward here.
Yeah.
This is Kiana Brown, Rutgers University. Thank you so much for this session. I am a epidemiologist. I'm also an advanced generalist macro level social worker, and I'm appointed at both the Rutgers School of Social Work and the Rutgers School of Public Health. And my issue, and my heart is racing fast, even asking a question. I'm essentially looking for tips. My issue is when it comes down to it, to changing the system for the better. And in my case, it's always around maternal and child health because that's what my research focuses on. So take, for example, the rapid legalization of cannabis across states in this country. That policy, coupled with antiquated discriminatory policies that criminalize prenatal substance use, right? How do we, and of course, Black women and women of color are often reported. I think Dr. Sachs brought up the point of social workers taking people's children away and all of that. That is absolutely true. And Black women and women of color are often reported more to social services for prenatal substance use than non-Hispanic white women, even when there's no difference in substance use. This is basic discrimination, right? Mm-hmm. So when it comes down to it, and you say, what can I do to change the system? I hear from the social work standpoint, not at Rutgers particularly, just in my experience in general, from both the social work side and the public health side, I hear something like this, and it was even mentioned today. look at your individual reasonings for, whatever. It's like we always, the onus of changing the system is on the individual. That is not helpful for me, and it's almost impossible. It's like, what can we do to really change the system outside of running for policy? I mean, running for office. What is it, something that we can do besides being an individual do-gooder? Like, is it something objective and tangible? Can I walk away with a skill outside of thinking in 10 to 15 years, I might have to run for office by force? And I would love nothing more but to do science all day, every day until the day I retire. I don't want to run for office, but I want the system to change. And it's and it doesn't. And what do social workers do? If we're in social services, we continue to our job, we continue to take these kids away. We continue to implement these racist policies, and it's nothing we can do as a collective. That's where I'll stop. And
Okay.
because maybe someone will give me a tip.
Okay, good question, Dr. Brown. So in 2 minutes, and I know that's not a lot of time, but Dr. Tina, Dr. Gino, response to that, because you all have hit upon that in various and sundry ways in your presentations. The profession has that history. And running for office is a good thing. We need more social workers in office. I wrote about that.
Yes. Yeah. I mean, Dr. Kiana, I just want to say, I see you, I feel this frustration, I recognize your frustration, and thank you for your work. And what I really think about this is that again, this whole entity, this whole thing, this country, it's built on a very, very problematic platform. And it predates us. This is a long battle that we are in. And I think one of the things I think about a lot is how I can individually make a difference, and how I can also be part of a collective that can also change this. And so I don't see it as sort of one or the other. I really see it as both and, which is that I try to do what I can do with my own voice, with my writings, with the way I teach, with the students I mentor, with the kinds of scholarship that I'm interested in, where I also vote with my pocketbook all the time. I try to support things, monetarily that are important to me, that are, with my own value system. And then I also really do think that as social workers and people who have, particular knowledge of systems, that getting involved in policy debates and in politics and in activism is something that is, although it's frowned upon frequently in the academy because it's not neutral enough or objective enough, or that's at least the way it's characterized. But I think that we see that is one of the ways that change happens, and that social work had a history of being a profession that was interested in making social change. And there were radical social workers, there were Black social workers that were really pushing on this as a profession to say, we need to do better, and we need to be real change agents as opposed to supporting or facilitating the status quo. And it's a hard way to go. It's a hard path to walk, but I think it's one that we have to make some decisions about if we want to, go that way or not. This is not something that's going to easily change, because it's been, at least on the shores of this country, right? This is the United States was essentially predicated on blood of the genocide of Indigenous people and the enslavement of Black people. So, this was here long before us, but we got to just keep chipping away.
Yeah.
Gina?
I too want to echo, my hope is that you keep your passion alive, your integrity as a professional. And it isn't just micro. We've compartmentalized practice, micro, macro. We have to focus the both and, as Dr. Sachs has communicated. And so I started my career as a social worker at a micro level, working as a clinician at Drew Child Development Corporation in Watts, their child abuse treatment program. But I learned and trusted that while my advocacy was at a micro level, I had opportunities to write reports that went to the judge and the courts in making permanency planning decisions, and I could impact trajectories because of my reports and the information I was providing. And so I have moved into more macro level practice, but I've come to appreciate incremental change is still meaningful. And we can plant seeds both by our individual efforts, but our collective efforts and partnerships as well. And while the change we may not even see so profoundly or robustly in our lifetime, it doesn't mean that we're not having impact. When I write a report or I testify, I'm impacting all those people in the court. I'm educating them. When I testify next week to the state Senate, I'm educating them about things that they may be clueless about. But incremental change is laying a foundation that for future change and more systemic change to occur. So I don't lose hope that right now I can't change everything because I am changing things poco a poco, little by little along the way. And those successes build confidence for not only myself, but the community, because they're seeing those successes as well.
Thank you. I do want to just mention there were 2 questions or 2 points in the chat. First, really public health social workers within SSWR and working collaboratively with the public health section of APHA. I believe one of the most important things is we're doing now is submit those papers, come together, submit abstracts, have special interest groups within that and have some dialogue going back and forth there. Another point I believe is very important is the tenure process and how it's looked at, particularly when our work is around the issues that we talk about of race and gender and marginalized populations. Our work is good. It is needed. And I believe that work stands on the shoulders of others when we go in and we put in our applications. And having the mentors such as Dr. Francis, Dr. Taylor, and others who've gone before us who can help us say, this is what you need to put in your packet. This is how it is. But the work is needed. We need to break down those barriers that we know still exist in the academy. We must be bold and do it because this nation still has a lot of problems, as we all alluded to here today. I mean, we could talk about this many more hours, but we do have another meeting at 2:30, the membership meeting, so I hope everyone will attend. I would like everyone to please give a round of applause for our panelists today. I appreciate your knowledge and everything that you shared with the group today. I hope that you all will continue to seek out opportunities to expand and address the importance of social work, meeting and working with populations that we know need our expertise. And as Dr. Gino said, and Dr. Tina said, let's not just parachute in, get the data and go back. Let's go in, listen. Social workers, our #1 skill is listening so that we can really do something and admit that we don't know everything. Everyone, please be safe out there. Stay strong, stay safe, and we'll see you soon. Thank you very much for attending.
Thank you, David. Thank you, everyone. Thank you.
Thank you so much. What a great presentation, great opportunity. Thank you.
Yes. Thank you. And do your poll.